just, from broad picture, before getting to some specifics, it's useful to step back and, say look at where we are collectively in the fight against HIV, TB, and malaria, and also in global health more broadly. And one of the most exciting things about right now, I don't think there's been a more exciting time to be engaged in these issues, because the science has gotten us to the point where we can see how to end these epidemics as public health threats. We're not there to end them entirely yet, but we can end them as public health threats. And that's something we couldn't have said 2 years ago. And that makes it an awfully exciting time. What makes it equally exciting is that we've invested so much in the last 10 years that we can use the science. Sometimes you have science and have no idea what to do with it or can't do anything with it. But because of the investments, because of the work you all have done in countries and supporting national programming, we are at a point where we can actually take the science, take the epidemiology we have on where the infections are, and implement and actually get towards that goal. And then with just a little more scientific advance, just moving towards partially effective vaccines, because if we interrupt the transmission so dramatically, we actually don't need 90% effective vaccines. We could probably get away with 50 to 70% if we use the science we have today. And that's possible for all three diseases. Certainly malaria and HIV, we hope TB, with 12 candidates in the pipeline. Hopefully one of them will work out. The flip side of that is if we don't engage now, we'll lose that moment. We'll lose that historic window. And that's because infectious diseases don't follow budget cycles. They're not aware of what's happening in the financial community. And these interventions, this new science is only partially effective. So it'll work if we're on the downswing with HIV, TB, and malaria. But if we start creeping up, which we know we will, Uganda's got increasing incidence despite very good programming. Not because there's a problem, because it's a mature epidemic. It's the same thing we see in Canada and Europe and the US and high-risk groups. The science isn't going to be good enough. And we know in malaria that if we take our foot off just a little bit, malaria will come back. And TB is actually in some parts of the world, Eastern Europe and even places like South Africa, already on the rise again. So if we let that happen, we don't have the science, which means that there'll be more generations of grandmothers that have to deal with this, or we could deal with it so that our grandchildren don't have to deal with these epidemics. And that's the historic question, and that's the historic opportunity before us. As exciting in many ways is, as we understand each of the three epidemics more and know the epidemiology more, the people most at risk of infection today are the marginalized, most vulnerable people in our societies. They're young women, they're gay men who have sex with men, they're sex workers, people who inject drugs, prisoners. And so to fight these epidemics, we have to actually change our approach to the human family and actually expand and grow the human spirit in a way that fundamentally changed the paradigm for how we treat each other as human beings. And that means engaging civil society an awful lot more and understanding that the health system doesn't end at a clinic. To reach the most vulnerable, to welcome them in the human family, takes a lot more. And it's going to take more than the formal health sector. But it's also a remarkable opportunity to end three plagues, two that have been around for thousands of years, one that is the modern-day Black Plague, while we expand and promote human rights. That's pretty cool. You don't get many chances to do that in a lifetime. And that's why it's such an exciting moment, such a remarkably exciting moment. And the Global Fund has evolved to be in a position of strength to actually contribute in a significant way to achieving those goals, to ending the epidemics, in multiple ways. Including expanding health systems and strengthening our ability to have a platform for other health interventions. And that's pretty exciting too. So a couple of the things in terms of evolution of the fund is our new funding model really gets back to the origins of the Global Fund, which was created as a 21st century institution. It's the only multilateral, Gavi just missed it, to be created in the 21st century. And to be created for a different approach to development, to move past the paternalism of the past, to move into an era of partnership amongst the development partners, but most importantly, partnership with the countries in support of country ownership. And that's why the Global Fund only has staff in Geneva, because we're supposed to be working through partners. Partners in bilateral organizations like CETA and other technical organizations of the United Nations and other bilaterals, partnering with implementers such as yourselves, and fundamentally partnering with the countries, all parts of the country, and the private sector. And that partnership is how we are going to tackle development problems in the 21st century. And the new funding model is to really evolve and fully capitalize on that, that key insight that we had to do things differently. And so we've switched our systems around so they align with the national health strategies, so that they align with the country and planning cycles of the nations themselves rather than our round system. And so that all partners can come together through a partnership dialogue before a concept note or a grant application is created. So that instead of retrofitting decision making after a grant is awarded, we do it before, so that the grant is disbursement ready, and that we can move much faster. And it also is going to, because of what we talked about at the beginning, be necessary to understand current epidemiology for HIV, TB, and malaria in countries before you get to that, before you can actually plan and strategize, because you need to know where the infections are, you need to know who's most likely to be infected, you know which interventions are most likely to inhibit that transmission, but also provide the best support for care and treatment. And so that dialogue is where civil society needs to be fundamentally engaged, whether you're an implementer or not, to ensure that people are looking at how best to tackle the epidemics, and that the concept note is the best possible among all the partners to achieve the goals, and aligned with the country, and pushing the countries to increase their own contributions, so that for the future, that's where we need to go and how we lead. And it's really an exciting time. And the early going looks pretty good. Not perfect at all, but looks a lot better than we did. And we're very excited about it. And then after we go through this first round, we will take a look at what worked, what didn't work, and then move on from there. Now, a lot of people were confused when they saw our 9 early applicants. We were all over the place to some people. We were intentionally all over the place. The purpose of the early applicants, which is something I would not want to be, you never want to go first because you're basically the guinea pig, was to look at different environments. And that's why we had 3 regional programs. One in Eurasia, which is a non-CCM, a non-government proposal, because to deal with harm reduction in that part of the world, you basically have to work around the government. 2 other regional programs, one in Mesoamerica to eliminate malaria, which we can do, we absolutely can do, and one to deal with drug-resistant malaria in the Mekong Valley, because if we don't, we're going to lose out all over the world on malaria. And then 6 countries spread across HIV, TB, and malaria. And they look different because we need to set patterns, because how we engage needs to be country specific. The partners that need to be around a table, the type of partner that needs to be around a table is going to vary greatly based on the country and region we're in. The type of grant we'll pursue will look very different in Latin America for the most part, except for Haiti, than it will in Africa, than it will in Southeast Asia, than it will in Eastern Europe. And a regional program will look different than a country program. So we wanted to have that full diversity, which our board asked us for, so that we would set patterns that could then be used as we scale to a global increase. Now, to achieve all of this is going to take money. It's going to take operating in a different way and getting more for the money we have, but it's going to take more money. And that's why we've set a very aggressive replenishment goal of $15 billion. Which is a 50% increase, 15 billion US, so less Canadian, given the fact that you all are doing a lot better than the US. That's a 50% increase from last year. And in this environment, that's pretty tough. But we didn't set it, in the old days of development, you would just set a dollar amount and see what you could get for it. Not a very good approach to development. So what we're really trying to do is say, what's necessary to achieve this vision we're talking about, to ending these 3 diseases as public health threats. Because we need to act in these next 3 years if we're going to succeed. How much will that take? And then let's go try and get it. Whether we get it or not, let's go try and get it. And that's $15 billion. And that was developed by our partners, by Roll Back Malaria and Stop TB and WHO and UNAIDS. And that means that is not what it's going to take to achieve that, but if the Global Fund's share basically remains the same, we're not trying to pilfer from bilaterals either or from the UN family, but if our share remains the same, to achieve 87% of that goal of control, that's what it would cost. And we think in 3 years, 87% is about right, because this isn't going to be done in 3 years. We're going to need another 3 years to get as far as we need to go, and probably even beyond that. But if we can do that in the next 3 years, that's pretty exciting. So we think the case is compelling. We've gotten remarkably positive response from countries, even with countries with declining aid budgets, even with countries with tough financial times. They're really looking at what can be done and where there's always opportunity. We're still a very wealthy world. We're in tough financial times, but we're still a very wealthy world. And this is something, the opportunity cost is too high. And the loss of return on investment of the last 10 years is remarkable, because we will not fulfill the return on investment that we could from what was done the last 10 years if we don't invest a little bit more now. So it's an exciting time, but it's only going to happen when we all work together, whether it's through advocacy, whether it's through implementation, whether it's through this vision of how we end the diseases. The global conversation needs to change, and we can only do that together. And more importantly than the global conversation, what's happening in countries needs to change. And we have the opportunity to do that today, and we'll do it if we all do it together. And so we're really, really honored to be with you today and look forward to the conversation.